All right, we are going to get into our case study. So we have a 29-year-old G3P0. She's had 2 spontaneous abortions. They were early miscarriages. She has a family history of congenital heart disease, specifically HLHS, hypoplastic left heart syndrome, and a family history of chromosomal abnormalities. Indication, there was a suspected abnormality at her OBGYN at that 18-week anatomy scan. At the time of the maternal fetal medicine evaluation, cardiac findings were consistent with hypoplastic left heart syndrome, and there were extracardiac findings that were also found. All right. As we discussed earlier, the first thing we do is establish fetal position. With that said, I do just want to mention these are real world images and they were technically challenging. And, you know, we're all sonographers and I think we all understand the challenges of ultrasound. Not only do we have challenges when scanning normal babies, but the added challenge of scanning abnormal. So yes, babies breach. Now that we know the position, let's go look at situs. All right, so we see a normal configuration of normal visceral situs, stomach's on the left, and that heart, the cardiac situs is pointing towards the left. Yeah.
And I love case studies that are actually representative of real world. I mean, because we can all picture these pristine glass images, and but that's not what we're dealing with day in and day out.
That's very true. Yeah. All right. So let's get into this heart. So on the grayscale side, we're seeing a right heart, or right heart is dilated, right? Right atrium and that right ventricle. And then we're not really seeing much of the left heart. And then if we come over and look at our color view, we're seeing aliasing. We're seeing a very broad jet, which it appears that there's tricuspid regurg, which regurg coupled with that dilated right atrium. We're going to put a pulse wave in it too, just to evaluate it even further, which yes, then proves regurgitation. Thank you.
I'm sorry, I'm a little slow with the mouse here, but I think your point is one that is probably worth, you know, mentioning and highlighting is, you know, when you have a dilated, that's obviously a markedly dilated. If we go back, that right atrium is very dilated. I don't think anyone would argue with that. And so what's the first thing you should be thinking about, or one of the first things is, okay, let's look at that atrioventricular valve, because this looks like a volume overload state. And then you've confirmed that beautifully with the color Doppler, and then just confirmed it again with the spectral Doppler. So it's using every tool in your toolbox there.
Okay, so let's look at our first clip. So it's that apical view that we're obtaining with the apex pointing down. That ultrasound beam is parallel to the septum, just a reminder. And what stands out here, we have a dilated right atrium, right ventricle, and we still don't see much evidence of a left ventricle.
Yeah, you would expect to see something right there, and you just don't pick it up.
Yeah, we're just not picking it up in this plane. And then also, which I'll have you point to, Jason, we can see a dilated coronary sinus.
Yeah, it'll be right in here. Let me see if I can freeze this image.
Okay. And that would be due to the pressure and volume overload, is what we were thinking.
Yeah, so
Right.
So here, if you look here, this is the right atrium. This is the level of the tricuspid valve annulus. So we're right on the AV, right above the AV groove. And you can see this is the actual coronary sinus draining into that right atrium, which should not be that large.
Mm-mm. And then also on that clip, we're seeing, we're suspicious now for pleural and or pericardial effusion.
Mm-hmm.
Yeah. All right. So let's see. Okay, so this one's nice because we can begin to see part of that right atrial appendage.
Yeah, right around here.
Just like we talked about with the morphology of the chambers, that's something that we can use in this case. So we're seeing abnormal. We believe it's the right atrium that's dilated, but now we know that is morphologically the correct layout of the heart.
Yeah, and you know, something else that's probably worth mentioning is in the previous image, we saw the coronary sinus draining, and that's a posterior structure. And so to get this atrial appendage opening, you've got to sweep up a little bit more anteriorly through that heart. And then you start to see the opening, the mouth of that right atrial appendage. So again, it just kind of stresses the importance of if you're just taking a two-dimensional frozen image, it's really tough depending on the level that you acquire that image. You might be posterior and you see coronary sinus, but you might miss that right atrial appendage if that's all you go on. So that again kind of speaks to the beauty of the cine loop to me.
Yes. Yeah, and we're still seeing, not seeing really any evidence of that mitral valve.
Yeah.
Or left ventricle.
Yeah.
All right. So now we're looking at the subcostal view, and this is just like we talked about earlier, good to evaluate the heart in two different planes. And we see a dilated right atrium, dilated right ventricle, and then really just starting to see, well, a rudimentary left ventricle might be right in there. Yeah.
Yeah, could be. At least it raises your suspicion.
Yeah. Yeah.
The other thing I would say about this is a great example of what we talked about earlier, abnormal cardiac axis.
Oh, yeah.
So if you look at this, the spine is here, frontal chest plane is here. So this is very markedly abnormally levo-rotated position of the heart, yeah. Which again carries a high incidence of congenital heart disease. So
thank you for pointing.
Just a little side note.
Yeah, that's a good one. So that axis is off. Okay. And then here we have another clip that we are looking at here. And we're actually seeing that left ventricular outflow tract and a left ventricle, a small left ventricle. What's great about this also, we see the outflow tracts are crossing. So even when we have, you know, a complex pathology, it's like we can still prove, you know, look at the fourth chamber, look at the outflows, like we're showing here that they do cross. And it does look like that LVOT is small and narrow. And then what else do you see, Jason?
Yeah, to me, this is the persistence and the beauty of what we do as sonographers is if you can't see things clearly from one projection, you move to another. And you can see the difference. And just this sonographer obviously was trying to better delineate anatomy. And by switching planes and views, you can see now there's no question. There is definitely a diminutive left ventricle here. There's definitely a left ventricular outflow tract and a small ascending aorta there. You also see normal crossing, so the great vessels are in normal relationships. You can see there's a little circumferential pericardial effusion. Oops, sorry. Sometimes I get button happy. You guys are just going to have to bear with me. It's, you know, You've got an old guy operating a remote control on a TV. Okay, that's what's happening here.
You said
So you see a lot of different information. You also see, you know, back to when we were talking about papillary, the right ventricle, some of the anatomic features. There's definitely a papillary muscle attaching to the septum. So that's not scared. That is then septophilic, which then tells us that is in all likelihood a morphologic tricuspid valve. So there's so much information you can pull out of this one image.
just from this one clip. Yeah.
Yeah, it's great, great view.
Okay. All right. So now we have a sagittal view, and again, looking at that right atrium, but we see a dilated IVC, and that is actually the backup of flow is even going into the hepatics. And, you know, again, just thinking of all that pressure from that right atrium. Let's see. And here is a nice little live clip. Just we see SVC and IVC, and they both look dilated.
Yeah. When you put that much volume, when you volume expand and overload a chamber, particularly an atrium that isn't muscular, so is not able to compensate as well as one of the ventricles, you see faster backup then in congestion into the veins leading into that chamber. So, and that's what's demonstrated nicely here.
Yeah. All right, so let's look at the extracardiac findings. So in the profile view, we see that profile looks flattened. And then we have a thickened nuchal fold. And then dangling choroid. So we're looking in that atria of the lateral ventricle, and we see that choroid there. And then looking for the CSP, it could never be clearly delineated. And then we also had bilateral pleural effusion, an echogenic bowel, and a thickened bladder wall.
And I think one of the most noteworthy points about this is you have a cardiac guide pointing out this anatomy as you call it out. And so
thank you.
That's what we mean by multidisciplinary.
Yes. You did great, Jason.
Thank you.
So yeah, so let's talk about differential diagnosis. You know, as sonographers, like we said, we're always thinking differential diagnosis. So we can talk about differential diagnosis of the heart. So with the added views of the outflow tracts and that 3-vessel view, we think left heart pathology. But adding in extracardiac findings, I think it really makes us suspicious for a potential syndrome. Yeah.
I agree.
Yeah.
And it's very difficult. It's not always easy to pin down what is the exact insult or what is causing this left side of the heart not to grow and develop. So Amy is absolutely on point. You have to think of many different things, from coarctation, you know, of the aorta to mitral stenosis to any combination thereof. So you really, you know, it should just get your brain working in that mindset.
Yes. All right. So patient opted for an amniocentesis, and it actually showed positive for a very complex chromosomal abnormality. So, patient was then referred to pediatric cardiology for further diagnostics and genetic counseling to discuss the significance of these findings.
Okay, so as part of the kind of natural progression from one team to the other, we do pediatric cardiology consultations. And why do we do that? For a lot of reasons. Identification of, as we kind of alluded to in those previous frames, we want to kind of pinpoint what is the exact etiology, what's the cause of this abnormality. By doing that, we can then risk stratify with the patient and educate the patient on this is what's happening, this is the experience with this particular subset of disease. This is going to be the most likely postnatal course because it gives parents a choice. And that's really important in many forms, specifically this very complex form of congenital heart disease. And once you give the parents that choice, then you can appropriately plan. And by that, a couple things, and we're going to go through this pretty quickly, but it's so crucial for the earliest referral to pediatric cardiology. And that's not because perhaps you're not able to, Amy does a scan and she says, well, this is a hypoplast. It's not that we feel like pediatric cardiology has to confirm and say you're right, but there are a lot of different subsets of this lesion. And so some of these are caused by things like, example, for aortic stenosis. There may be some fetal interventions that can be offered to patients that could affect the development and the progression of this disease state. We talk about pregnancy termination, which is absolutely on the table for these patients. This is not only a very complex congenital heart defect that's going to require a lifetime of very intensive cardiac follow-up. It also comes with a whole there's a slew of potential associated neurological defects. You're talking about intensive hospital stays for months at times. So, getting that in there early and allowing the patient to determine, have that choice of termination or palliative care. And then if you decide to move on, then we need to talk about surgical palliation, after birth. Again, this is a very complex congenital heart defect, and you've got to bring in multiple teams to address this. You've got to plan the delivery, the location, the timing. There are so many factors, and so the more time you have, the better we can optimize ourselves for the best result. We talked about the hypoplastic left heart syndrome, and we talked about congenital heart disease. And so we know that it's the most common congenital heart defect. In fact, about 1 in 100 babies are born with some type of congenital heart defect. Hypoplastic left heart syndrome comprises about 5 to 9% of all congenital heart defects. It is obviously one of the most commonly prenatally diagnosed heart lesions that we see. And hypoplastic left heart syndrome comprises of about 13% of all prenatally diagnosed congenital heart defects. It's broken down into 3 main types. When we talk about hypoplast, there are generally 3 different buckets that they fall in, and that's based on the inflow and the outflow to that ventricle. Really, despite what combination you have, what you're left with, generally speaking, is some type of atresia or hypoplasia of the mitral valve and aortic valve. You have a small or hypoplastic left ventricle. Your ascending aorta is then hypoplastic. These patients oftentimes will have coarctations associated with. Flow equals grow in utero. And so once you do something to limit the flow of blood, you're going to significantly impair the growth of those structures that are related to that circuit. So when patients are referred to pediatric and or fetal cardiology, what are some of the things we specifically look for? Well, hypoplastic left heart syndrome, like most forms of congenital heart disease, it's a spectrum. There can be mild forms, as you see here. This is a left ventricle that is small, it's hypoplastic, as is the annulus of the mitral valve, but it's not horrible. There is a functioning ventricle there. There is a mitral valve that is, opening and closing. Then you get some that are on the spectrum of a little bit more on the severe side. And this is more like Amy's case study, where you have a dilated, engorged right atrium. You have a very small, diminutive left ventricle, and you can see the difference. There's not a whole lot of organized cardiac function or squeeze to this ventricle. Another case where the left ventricle, you can already see there's a little bit of signs of some EFE. It's just very non-functional. You can't see the mitral valve really well in this particular projection. But one thing of note we talked about, or Amy talked about, I should say, is, one of the things you look for are the ventricles forming the apex together. Or you can look here, this right ventricle is certainly apex forming. The left ventricle doesn't even come close. So there's a lot of variability. One of the things we obviously are very important to us as we evaluate is the aorta, the aortic root, and the ascending aorta. And we want to know what the size of that is. What do we have to work with there from a surgical standpoint? So in doing that, we try to, elongate the ascending aorta. We take careful measurements of that. We also assess the ductus here. You can see kind of switching back and forth from ascending aorta to the ductus. This is going to be a ductal dependent lesion postnatally, for systemic circulation and output. So we look at that carefully. One of the key points to this, when you have a significant hypoplastic left ventricle setup, is retrograde filling. And so this is something that's really important, because we don't have a significant amount of prograde flow going from the left atrium through the mitral valve, left ventricle, across the aortic valve, as in normal fetal circulation. We start to see retrograde filling. So there's nothing really coming out of that ventricle. Well, we know a couple things. One is the aortic arch has the vessels that perfuse the head, neck, arms. And so we have to have blood flow, as does the coronary arteries that actually perfuse the myocardium itself, sit down in the aortic root. And so we start to see retrograde filling of that ascending aorta and the head and neck vessels. And that's really important to evaluate and look at carefully. Part of that, we won't go too deeply into this, but we always evaluate the middle cerebral arteries, because again, perfusion of the head can be compromised with a severe hypoplastic left heart, and it's relying on this retrograde filling. And so when we evaluate the MCA, you see a normal pattern here, and then you see what we refer to as brain sparing down on the graph below. Atrial septum and pulmonary veins, critical part of the evaluation in a hypoplastic left ventricle. And what we see here is we see this nice floppy foramen ovale, and then we see the pulmonary venous inflow to that left atrium. Because there's so much resistance now, non-compliance, you can see this ventricle, it's bright, has EFE, it's, it just looks nasty. It's very difficult. Blood is going to go the path of least resistance. So it's much easier for that blood flow to go across from left atrium to right atrium than it is to try and get into that ventricle where there may not be any egress. So we always look at this very carefully. And the reason why is because there's a subset of these patients, about 6 to 11% of all patients with hypoplastic left heart syndrome, that have a restrictive interatrial septum. The problem with this is when you run across a case like this, they have a very high mortality rate despite surgery or immediate palliative procedures postnatally. In fact, pre and early postoperative mortality is about 50% for patients that have a restrictive interatrial septum. And so one of the things that we evaluate very carefully to be a good predictor for us, on the left you see this is a spectral Doppler of a pulmonary venous inflow. This is nice and normal. And so by doing a VTI trace for the forward flow and the reverse flow caused by the atrial contraction, we come up with the VTI ratio. And as you can see on the right, we go from normalish to progressively worse to this is trouble. So anytime we have a VTI ratio of less than 5, that is the strongest predictor that we have that's going to tell us this baby is going to need an emergent atrial septostomy in the newborn period. Again, that's one of those factors that really plays very heavily on determining where the patient is delivered, when the patient is delivered, making sure we have the right teams in alignment on that delivery. Or potentially being there and diagnosing that, because maybe you can do a fetal atrial septostomy where they go in and actually with a needle go through the abdominal wall all the way through the heart and place a stent across that atrial septum to help alleviate some of that restriction. But most of the time what we see is, we want to make sure there is a rapid delivery, rapid transport to a center that's capable of doing an emergent balloon atrial septostomy. So we go on to delivery. So we've got the teams involved, we've got the prenatal diagnosis. One of the things, or I should say, some of the things that we look for when we're doing the first postnatal evaluation of these patients are, what is the function of that single ventricle? How is the contractility? How does that AV valve function? We're looking specifically for atrioventricular valve regurgitation. We want to evaluate that atrial septum. We again assess the pulmonary veins to help us with that, and then we evaluate the aortic arch and ductus and the direction and how much flow is going there. So this is just a transthoracic echocardiogram after birth. This is a parasternal long axis, and so what we see here is this left ventricle, and you can see it's very stiff. There's not much contractility when you look, certainly compared to the anterior wall of the right ventricle. You can see it's briskly contracting. You see that a little aortic valve here, aortic root. Don't see much of the ascending aorta here. But even the mitral valve, there's not much excursion that we're noticing there. So we'll look at an apical four-chamber view. Kind of looking at the same thing. We have a left ventricle that's hypertrophied, it's thickened, some EFE. There's not a lot of contractility. You see the RV function here looks quite reasonable. And even if you look here at the septal configuration of the atrial septum, you see it bowing markedly over to the right. Again, AV valve regurgitation is an important part of the assessment. Because you now have one ventricle doing the job of what should be two, it's imperative that this ventricle functions as efficiently as possible. And the more flow you have going the opposite direction, the less efficient this ventricle then becomes. And then back to Amy's case, you also run into volume overloads and a lot of other problems that just continue to go down that pathway. The ductus, we talked about this. So this is kind of a high parasternal short axis projection. So we have the very left of the screen here. This is the ascending aorta on FOSS. And this is the main pulmonary artery. You see the right branch pulmonary artery, the left branch pulmonary artery, and then the ductus arteriosus is here. And by color flow imaging, you can see there's nice patency of the ductus with some bidirectional flow. When we talked about the retrograde filling of the ascending aorta, this is a great example. So this is a view of the aortic arch. And so the aortic valve sits in this region. This is ascending aorta. And you can see it is very hypoplastic, very small, particularly when you compare it to the size of the descending aorta here. So when you look at color flow imaging, this is all retrograde filling of that ascending aorta. And then you see the retrograde flow going up towards the head and neck vessels, again, for perfusion of the upper body. Critical here for the ascending aorta because you've got those coronary arteries down sitting in this aortic root. And if they're not getting adequate perfusion, then that right ventricle is going to, it's going to be very problematic as well for the heart muscle itself to get oxygen. So it's something we pay particular attention to. And then we get onto the atrial septum. And this is just a couple of examples of when you have a restrictive atrial septum. Here in the left image, this is the left atrium, right atrium, and you can see, you don't want to see this jet that looks turbulent and higher in velocity. And the same thing here. So two things that are preoperatively interventions that you will typically see with these patients is, number one, the ductus. This is a ductal dependent lesion. So if you don't have a patent ductus, you're not going to have systemic outflow. So they'll start prostaglandin therapy to maintain the patency of that ductus. It just keeps that ductus open. And then we can do balloon atrial septostomy or stents to help decompress that left atrium in the pulmonary venous inflow. Again, 6 to 11% of patients with hypoplastic left heart syndrome have this. And the really thing you need to take home is if you don't do some type of decompression in a patient with restrictive atrial septum, then survival prior to stage 1 surgery is about 10%. Okay, with decompression, the survival rates range from about 30 to 70%. So it's a critical thing to look for and make sure you're prepared to do. When we talk about balloon atrial septostomy, this is where, you know, echo kind of, you know, shines. We typically do these under echo guidance. And so you'll have a cardiac interventionalist that will actually feed a wire up into the heart that has a balloon on the tip of it. And so with echo, we're sitting here getting these images and we're trying to help guide that cardiologist. Okay, you're looking good, you're almost across, and you kind of guide them across the septum. And so it can be difficult and challenging. There are some other modalities. The image on the right is a three-dimensional rendering of the same patient. And if you look down in this area, you see this black circle. That's the actual mouth of the inferior vena cava. And you can see this catheter coming up from below, arching up through the right atrium, and now is crossing the atrial septum. And so it's, you can use, just back to what Amy said with color and spectral Doppler, three-dimensional imaging can be just another tool that we use to help guide these interventional procedures. Once you do that, you can see here clearly the wire is all the way across the atrial septum. Here's the atrial septum. And then the interventionalist will blow this balloon up. And you can see the narrow point when it's blowing up, it's a little waist. And so we're hoping the end result of that is it stretches that atrial septum such that we can now have unrestricted blood flow from left atrium to right atrium. Some cases, these atrial septums are so thickened and muscular in nature that you can't do it adequately with a balloon. And so they'll deploy oftentimes a coronary artery stent across that septum. So instead of deploying the balloon, they'll place this stent across the atrial septum to open it up. It's a rigid stent. And so you can see on the right, you now have egress from the left to right atrium. Well, I was supposed to take that slide out. It's the only time that one of the cardiac cath docs will say thank you to echo people, because we all think each other are voodoo magic. You know, it's always a running joke in cardiology. We won't spend time there. But so now we've palliated the patient. The patient is stable postnatally. So now we're talking about surgical intervention. What is the goal? Well, we have to balance the flow between the pulmonary and systemic circulations, and then ultimately separate the two circulations over a series of surgeries. And so we're going to talk about the Norwood today. There are a couple of other options, one being cardiac transplantation. There's a hybrid approach that we're not going to get into for the sake of time. This is the most common, and it's a 3-stage surgical palliation, okay? And we're going to break down the individual stages and just kind of talk about each. This is stage 1, and this is typically done in the first week or certainly 2 of life, and this is called the Norwood procedure. And this stage carries the most risk. What we're going to do here is we have to create unobstructed flow from the ventricle out to the body. Okay, so we have to have good unobstructed systemic outflow. As you guys remember, we had this tiny little ascending aorta. And so part of what's done here is you kind of graft the main pulmonary artery onto that ascending aorta to effectively make a single great artery coming off of that ventricle that is then going to be, through the use of patches, going to tie in and become your aorta. So this is now the neo-aorta. So you have one outlet off of this one great ventricle. You can see here they've removed the branch pulmonary arteries from the heart. And so once they do that, well, obviously we have to provide flow. So we put some kind of connection in. In this case, it's showing a shunt from the right subclavian artery down to the right branch pulmonary artery, so that you have somewhat of a balance of pulmonary blood flow. The other thing they do is because that restrictive atrial septum can be so detrimental, they'll typically go in and do an atrial septectomy, just remove the atrial septum. So effectively you have one large atria then. And so there are generally two different ways to accomplish this. There's the Norwood shunt or a Norwood Sano. And the difference is on the left here, this is what you see. This is a shunt, typically a BT shunt, or in this case, this is a modified using a Gore-Tex tube. So this is what a BT shunt looks like. And then the Sano modification is a shunt that goes directly from the right ventricle out to the branch pulmonary arteries. Now, when we look at this, one of the things we need to look at very carefully from an imaging standpoint is when you anastomose the aorta to the main pulmonary artery, it's typically done in what's called a Damas K stanzal or a DKS connection. And so you have to make sure that in this, on the lower left, you see this is the native ascending aorta. And so there's a wide open connection between this now neo-aorta coming off. And again, the reason that's important is because you've got to get blood flow coming back into that ascending aorta to perfuse those coronary arteries, okay? So we've got to make sure that's wide open. And then you also want to always take a look at, because coarctations are often associated with these, you want to take a look at the distal arch. And this is in fact a residual coarctation at the very distal end of this patch you see up in the cartoon. With a modified Blalock-Taussig shunt, what you're going to see is high velocity, continuous flow. So we have high pressure here in this aorta, in this great vessel, coming down into the branch pulmonary artery. And so the flow by spectral Doppler that we see is continuous and high velocity, because again, the pressure in the aorta is greater than the pressure in the pulmonary artery. And it's aliasing very high velocity. With a Sano modification, where again you have this, this tube from the right ventricle out to the branch pulmonary arteries, you see a couple different things. You see what we call the hood, or the little patch where they actually sew that onto the ventricle, and then you can see the connection going out to the branches. So both accomplish the same thing, just a different way to do it. Of note, a Sano modification, you're going to see a much more, because this comes directly off a ventricle, the flow in it when you evaluate it by spectral Doppler is going to be pulsatile in nature. So we've gone through the stage one. Now we're in kind of what we call interstage, in between that first and second surgery. And this is really when these patients are at their most fragile. Mortality risk is about 5 to 10% during this time period. And so they will go into programs called the Champion program at Phoenix Children's, or interstage monitoring, where there are daily communications with the cardiology team, talking about the baby's weight, heart rate, oxygen saturations, monitoring the dietary intake very carefully. There are cardiology office visits every 1 to 2 weeks. Oftentimes, you'll be required to stay in the area of the hospital, like here in Phoenix. You know, we don't want someone living 2 hours away. So they'll actually have to relocate and live here during this interstage, which can be anywhere from 4 to 6 months. You know, so it's a tremendous burden on the family. It's a very fragile time for the patient. You know, they're monitored very, very, very closely during this process. And then we get to stage two, and that's the Hemi-fontan or bidirectional Glenn. And so, you know, again, we're staging this operation out. The goal of the Hemi-fontan or Glenn is to connect the superior vena cava to the pulmonary arteries. So we're going to remove the superior vena cava from the heart. So instead of going back to that right atrium, all that flow from the upper extremities is going to be anastomosed directly into the right branch pulmonary artery. When we do that, we'll take down or ligate that BT shunt in this case. Now, the difference in the bidirectional glen and the Hemi-fontan, they both do the same thing and have the same goal. One is we're still working to balance pulmonary blood flow, but we want to start reducing some of the workload from that right ventricle. You know, as you guys know, typically we have two ventricles and two different circulatory, you know, circuits handling all the flow coming back, whether it's being from the lungs or the flow coming back from the superior vena or inferior vena cava. And so we try to take some of that workload off the RV, and that's what's accomplished here in the bidirectional glen. The SVC flow is diverted back to the lungs, removed from the heart. So you're accomplishing a couple different things there. And then the lateral tunnel, it's just a difference in the surgical technique and how they do that, but both effects are the same. And so echocardiographically, here's what we see with a bidirectional glen, which is probably the most common. What we're looking at here is the superior vena cava coming down, and this is the right branch pulmonary artery, and this is the anastomosis site. You can see it's nice and wide open, and so we're looking for nice low velocity phasic flow by spectral Doppler. So we live with that for a while, and then we get to our stage 3, or the Fontan, and this is when we really kind of correct the physiology. And so during this Fontan procedure, what we're going to do is somewhere between the age of 2 to 4 years, and what we're really looking for is for the pulmonary vascular resistance to drop to its lowest point. Again, keep in mind, we're now going to completely disconnect the venous return to the heart. So it's no longer going to see the heart at all. We're bypassing that directly into the pulmonary arteries back to the lungs. So we don't have a pump anymore pushing that blood to the lungs. So this is all passive venous flowing back. And so it's really important that our pulmonary vascular resistance then is low, you know, because flow doesn't want to go in the path of resistance. We saw that with the flow that was left to right across the atrial septum. It was easier to go across that atrial septum than it was into the left ventricle. And so we want to make the job of that blood flow to be as easy as possible to get back to the lungs. So the Fontan completion is generally done in one of two ways: a lateral tunnel, which you are kind of baffling in the heart. You divide the red atrium in half, and you are then kind of shunting that blood from the inferior vena cava up through this baffle back up to the branch pulmonary artery. So it never comes out and ingresses into the heart. Or it can be done through an extracardiac conduit, which is just as it says. It's just a conduit that is outside the heart completely. And so now we've rerouted the systemic venous return. So I want to talk about one thing that's pretty important when you do that. When you do a lateral tunnel, you'll see this little hole here. That's called a fenestration. And so surgeons will typically leave a fenestration there because, as we talked about with pulmonary vascular resistance, and one of the complications of a Fontan after the stage 3 is when you have high venous pressures, you'll start to develop pleural effusions because of that backup. And so to address that, surgeons will leave a tiny little hole in this baffle, and that allows a pop-off. So that if the pressure gets too high, your central venous pressure is too high, then you can pop off that blood flow into the heart to help control and mitigate that. And after time, you know, if necessary, they can go in and close this with a device in the cath lab, because this is deoxygenated blood. So it is going to lead to lower cardiac saturations in the end. Just a couple more views here as we close up. This is just a subcostal view showing the inferior vena cava coursing through the liver, and we would normally see it enter the right atrium here, and instead it's bypassed up through this tunnel all the way up superiorly towards the pulmonary arteries. another view, this is imaging from the patient's suprasternal notch. So this is the ascending aorta, the innominate vein, the SVC will be over here. And then by color Doppler, you see this red flow coming up from below, tying into the branch pulmonary arteries. And that's that flow from the inferior vena cava coming up. So one last look. So here's the superior vena cava anastomosis. You can see nice laminar low velocity flow. And then on the right-hand side, you see the flow coming up from below. Same thing, nice laminar low velocity flow from the IVC. Again, we're always concerned about atrioventricular valve regurgitation in these patients. We monitor very, very closely and carefully for that throughout. And then just a couple things. So when we've done this, you know, we haven't really corrected anything other than physiology and blood flow. And so doing this, you know, better than 70% of these patients now survive into adulthood, but they have very, their hearts are still very abnormal. You have to carefully follow these patients for life because you have these low flow setups. You have to constantly evaluate for obstruction, for thrombus. You want to look for that phasic flow. You want to look for dilatation of the SVC, IVC, hepatics. You want to evaluate the fenestration, ventricular function, AV valve regurg. These patients are going to be followed for their lifetime. They're going to be on significant cardiac medications for their lifetime. Some of these patients over time, because that right ventricle is not designed to be that systemic pump, eventually over time they'll start to, some patients will develop failure, some patients will develop arrhythmias, and so there has to be very close monitoring of these patients, again, throughout their life. And particularly for this audience, we have a lot of DMS folks on here. These patients often have, will develop liver and gut disease because of this physiology. So you'll be seeing these patients more and more and more. So those are kind of the goals of the study, but really the real goal is this. The real goal is us working together as a team and having this wonderful outcome. And this is where I want to kind of turn it back over to my partner, Amy, here, and let her say a few words.
Okay, great job, Jason. So meet Brody. This is my little cousin. He was diagnosed with hypoplastic left heart syndrome in utero. And everything that could have been done to stack this diagnosis in his favor was done, starting with that prenatal detection at the OB level. And because of that, the education, the delivery planning, and the complex postnatal surgical interventions were all made possible. And yeah, we're just excited to show you Brody. He's 8 years old now.
And he's a very svelte, stunning looking fella there at 8 years old.
He sure is, and he's pretty incredible. Yeah. Thank you. So yeah,
you know, in conclusion, and like Amy said, I mean, it's great when you have someone that has a personal tie, and when you see something like that, that is the outcome that we all strive for, and that's why we all do what we do, and that's why it's so important that we work as an integrated team. And it takes all of us, and it starts with that initial OB sonographer, and it follows through that journey, and everyone has such an instrumental part to play in this. You know, I hope that you guys on the OB side get to see the Brodies at their 8-year-old birthday party, because really that's the reward, right? That's why we're all doing this. And I also want to say, before we open to questions and answers and discussion, I'm very pleased to and thrilled to have Dr. Erica McLaughlin online with us. Dr. McLaughlin is a pediatric and fetal cardiologist at Phoenix Children's Hospital. I've had the great pleasure and honor of working with her and collaborating in the past. She is the director of the CVICU and Cardiology Fellowship at PCH, as well as the Director of Education for ECHO. She's a tremendous resource for the Valley here. And so I'm happy to have her on, because I'm sure there'll be a question that I have no idea what the right answer is. So I'm really counting on her to help bail me out. So I think with that, I'd like to just open up the forum. I don't know if there have been any questions in the chat function, but let's chat.
Awesome. Thank you guys so much for this wonderful webinar and information. There have been a couple questions that pop in, and then we'll get Dr. McLaughlin on as well. First off, I think maybe if we can go back, there'd be a couple questions with regards to the first image of the 4-chamber heart. Are you able to go back to that at all?
Yeah, I'm sorry. Which one? The initial?
The initial 4-chamber heart slide.
Okay.
There was a question whether the aorta was on the right, and would that make it complete situs inversus? I think it was the intro 4-chamber.
Look at slide 10, Jason.
Yes, or 11, yeah.
11, sorry, 11.
This slide.
Yes, I believe this is the one. Mm-hmm.
Okay, and
so the question was with regards to, I think one of the participants was questioning whether the aorta was on the right and whether that would be a complete situs inversus.
So I don't really recognize in this image, I'm not really evaluating or see necessarily the position of the aorta. I'm wondering if it was a dynamic clip after that prompted the question. If the aorta, if in this case you have levocardia, and this is a left atrium, mitral valve, left ventricle, if the pulmonary artery were coming off of this ventricle, meaning the aorta was coming off the right ventricle, that would be a case of D-loop transposition of the great arteries.
Oh, great. They wrote, maybe it was around slide 15, the slide with the various heart positions.
Let's see. Oh, I think it was your cartoon, maybe. Was it?
Talking about our cardiac situs here?
Yeah.
Oh, yeah.
Is that the one she's asking?
Yep.
Yeah.
Yes, this is the one. Yeah. The image on the left side.
Yeah, how that, we said that was abnormal.
Mm-hmm.
It might be referring to the difference in, like, when we talk about dextrocardia, is it mirror image dextrocardia? Dr. McLaughlin, are you on the call?
Yes, yeah, I'm on. I'm trying to get my video up and running, which it's not right now. So I think it just depends on what the, sorry, I'm seeing. So I think it depends on, so this is obviously dextrocardia with the apex pointing rightwards. And yeah, it looks like potentially situs, and I think it depends on what the other situs is. So again, when we're talking about our type of diagnoses, we want to look at all of the structures that are coming into it, because we're considering heterotaxy variants as well, and then whether again, where the stomach position is, where the liver position is, and then the venous structures coming in as well. I don't know what the specific question was regarding this, though.
Yeah, I think it's one of those things, to me, from what I'm picking up out of the question. There's really, like, this is just obviously a cartoon speaking specifically to, you know, levocardia, mesocardia, dextrocardia. When we're talking about situs inversus or abnormal visceral situs, we really have to look at all of those systems in whole to really kind of determine, you know, what that is, what the situs makeup is. But if you're on the call with that question and you want to unmute your mic.
Oh.
Okay, I think we can move on to the next question. There's a question with regards to pulse wave Doppler, and when has that been used to evaluate cardiac activity, as we were always taught to use M mode through all trimesters?
So by cardiac activity, I'm assuming that is referring to evaluating fetal heart rate and or rhythm.
I assume so, yes.
So I don't know exactly. I can tell you that when I started doing fetal echoes was probably around 1995. And the majority of people at that time were using M mode. In the mid to late 90s, we saw a dramatic increase in spectral Doppler sensitivity in echocardiography. And so with that increase, we started to realize, hey, wait a minute, this is now at least equally as effective as M mode was in assessing fetal heart rate and rhythm. M mode can be very challenging at times to use. And so I think with what spectral Doppler, bringing that into, I think what that does is it's just ease of use and speed, particularly in the OB and MFM world where, you know, I was, and Dr. McLaughlin, I will say, is very spoiled. When we do a cardiac evaluation, you know, something to keep in mind, we're blocking off a minimum of 60 minutes to evaluate the heart and cardiovascular system. You guys in the OB world on the front end of this are expected to do a cardiac screening as well as all of these other things that I can't even pronounce in such a compressed, condensed time period. So I think probably that's why it gained in popularity, was because it's just more efficient. And as the technology got better, we realized you don't have to have M mode to get that kind of sensitivity.
Yeah, I also, to your point, M mode can be, you know, depending on where you do or the technique, can be quite challenging. I think it's easier sometimes to get the spectral Doppler if you get mitral inflow and aortic outflow at the exact same time. And it's also a nice way, we're starting to calculate mechanical PR from those and using that for heart block cases, for example, and making actual quantitative measurements from those images with spectral Doppler versus using M mode. Another nice way to do it is in the long axis. You can open up your gate and do spectral Doppler from the SVC and the aorta at the same time. And sometimes it's a little bit cleaner than the M mode.
Thank you. This touches on another question that had come through with regards to what's the time frame for a sonographer to be expected to assess the heart in a routine anatomical study?
I think it depends where you work, number one. I know for fetal echo at my location, we get 45 minutes. So I do think it depends where you work. And then for the anatomy scan, we get 45 minutes also.
I will tell you that because as I said when we opened, I mean, prenatal detection rates of congenital heart disease has been something that's just been one of my top focuses for the last 15 plus years. And so I've had the opportunity to work with a lot of OB and MFM sonographers and practices. And anecdotally, I would say it seems as though most places and folks I have talked to are expected to do an anatomy scan in about 30 minutes. And that includes this fetal cardiac evaluation, which would terrify me.
I know. And I think that is accurate. Everyone I know who works in OB has about 30 minutes. Yeah.
Great, thank you. Do you recommend to place the caliper only on the left ventricle when doing the pulse wave assessment of the heart?
For rhythm assessment, for example?
Rhythm, yeah.
So for rhythm assessment, what we typically do will almost be, if you're in a 4-chamber image and then you go a little bit more superior and you're getting the outflow tract of your aortic valve, you can open up the gate to your spectral Doppler and get your inflow and outflow at the same time. It's a nice, so again, most people that do a fetal echo will take a spectral Doppler of the mitral valve and the aortic valve separately. And then if you're wanting to look at a rhythm assessment, You can do it by opening up your spectral gate and doing it at the same time by just going up a little bit more superiorly in the forechamber.
Yeah, I would agree. I think that when you're assessing cardiac rate and rhythm, and if you're going to do it from the left ventricle, as Dr. McLaughlin said earlier, a great way to do it, because your aorta and your SVC are parallel, your ascending aorta and SVC are parallel, it's very easy to open your spectral gate and sample flow in the ascending aorta and the SVC simultaneously. I don't see that employed as frequently as I do the mitral inflow and the aortic outflow. And the reason it's done in the left ventricle, what Dr. McLaughlin said, is the aortic outflow, the aortic valve and the mitral valve are in very close proximity. So it's very easy to acquire both of those at the same time. On the right side of the heart, the tricuspid valve and the pulmonary valve are separated by a lot of infundibular conal tissue. So you cannot get a simultaneous recording of tricuspid valve inflow and pulmonary valve outflow at the same time. So I suspect that's why most people do assess the left ventricle.
Thank you.
And that's that clip we had in the talk, right?
Yes.
I don't know if you want to pull it up.
I'm working on it. Gosh, you OB people are so demanding. That's what this slide shows. So you see nice mitral inflow, aortic outflow. 1-to-1.
Beautiful.
Beautiful. Okay, a couple more questions have come through. What is the success rate of these procedures in patients with extracardiac abnormalities, like in the case study?
So I came on after the case study. So what were the extracardiac anomalies?
We had a lot. So we had
Okay.
a flattened profile, thickened nuchal fold, echogenic bowel, pleural effusion, thickened bladder, arthrogryposis with the upper limbs. I mean, it was a lot.
Yeah, so in general, what happens with a single ventricle, so a single ventricle without any extracardiac anomalies, we're quoting them a survival of about 75% through that third procedure, the Fontan procedure. And obviously much more so if there's a restrictive atrial septum. If you had any sort of extracardiac anomalies on there or a genetic syndrome, that's drastically going to affect your outcomes or your survivability. There are some cases where, we've talked about the options for a patient, including termination and palliative care. There are some patients when there are significant comorbidities or an associated genetic disorder that we will not offer surgery and only will do palliative care options. And so I think depending on the patient, so for a patient like this, for example, it's hard when they have a partial trisomy or something like that, but we would certainly consult our genetics. So in this type of patient, when they came to see fetal echo, we would consult genetics and try to get what their prospective lifespan would be or the projected outcome from the genetic syndrome in and of itself. And then when you start adding other comorbidities onto that, then we would just discuss what the lifetime risk and what the lifetime medical complications look like. It certainly is concerning when you are compounding a genetic syndrome on top of a single ventricle and other comorbidities. So I would counsel this family in particular that they're that their lifetime, that they certainly would not be probably meet that 75% survival rate, would be much lower than that. Their length of stay, their ICU, and their other medical complications and comorbidities would also be significantly more as well.
Thank you.
Thank you. Yeah. When you're scanning these patients through these procedures, do you actually scan the patients with an open heart?
So two things. When we're talking about the echo-guided procedures prior to surgery, so the postnatal blue natral septostomy, we are typically not. That's typically done in the cardiac cath lab. Their chests are closed. They can be a little touchy because obviously the sterile field is very important. But you're still scanning typically from an abdominal approach when you're guiding those procedures. In the operating room, we always, most of the time we do echo as well, and that's typically through transesophageal echo, where Dr. McLaughlin would go up and slide an endoscope down that has an ultrasound crystal on the end, and we image the heart prior to, during, after surgery, so that when the surgeon goes in and, let's say, patches the aorta or does whatever they're going to do prior to coming, closing the chest and coming out of the OR, Dr. McLaughlin will be able to tell echocardiographically, yeah, your patch looks good, or hey, there's a residual defect, or we need to go back in and change this. And so we use echo extensively in the operating room as well. It's very infrequently, I don't know if you're referring to transepicardial echo. There are times where, for one reason or the other, we actually have to put the transducer in a sterile sheath and apply it to the surface of the heart when the chest is open. And Dr. McLaughlin, you can speak to this. In my experience, that's fairly rare.
Yeah, it's usually reserved for cases where a TEE is not indicated. So if a kid has an esophageal perforation or something where you can't get the esophageal probe down, that's usually when we'll do an epicardial.
That's a good question.
Excellent question. Yes, thank you.
Is there?
Okay, we're just looking for a couple more. If anybody has any last questions, what is the recommended safe exposure time with what value for thermal and mechanical index?
Wow, I'm so glad my colleague Amy is going to take that question.
Malka, you might know that better than me off the top of my head. Let's see. I know you're referring to the ALARA.
So I can tell you that from my experience, right or wrong, this has been, you hear this kind of bandied about, here and there when you're specifically when you're talking about fetal imaging. The first thing we do when we have very specific fetal presets on our machines. And so we always have our output power gain as low as possible to get the acceptable imaging. We generally don't think about it in frame of, I've been imaging now for 30 minutes or 45 minutes, because the power output is so low that we feel pretty comfortable with that. I mean, obviously, we're not going to go hold the transducer down, bang away with continuous wave Doppler, crank up our output power. Right. We would never do that. But I'm not aware of any specific time limitation when you're talking about evaluating the fetal heart, nor am I aware of any significant negative outcomes based on the ultrasound imaging of the heart.
Yes, I would agree with that. And also bring up, we're constantly moving. We're not just sitting on the heart in one spot. You know what I mean? We're moving that beam around. Yeah, and I mean, it's all under, the preset is gonna be within the guidelines, Yeah.
But I think this also speaks to the fact of this whole ultrasound physics,
Right. Oh, absolutely.
And the use of M mode, how that was historically, the lowest power output, and now we're more attuned to utilizing power Doppler and pulse wave Doppler, even though they have higher power outputs. We are trying to utilize the ALARA principle, and it's this cost benefit ratio. We got to find the answers from a more complex outcome.
Right.
But I would also throw another twist into this. You know, you guys are sonographers, and we know that one of the highest, sonographers carry one of the highest risks for musculoskeletal injuries. And so something that we've always tried to do with our teams, as Amy brought up, you know, in her case presentation, it's not always easy to image. Our patients, you know, can be diabetic, obese. They're very difficult. You know, when you're talking about an 18-week fetus, you know, the heart is the size of let's say it's a half a dollar. These can be incredibly challenging. So we oftentimes will have to remind ourselves, our sonographers, listen, don't sit in there for an hour and a half or 2 hours and put yourself at risk. Let's do the best we can, get the best imaging we can, because there's risk on the whole other side. It's a whole other side of that coin, but it's very real, particularly with imaging, fetuses.
Mm-hmm. Thank you. I think we have one last question so far. When you're performing a standard fetal survey, is it okay to change your preset to a cardiac preset when assessing the heart?
Yes, I believe it is.
I would even say probably not just okay, but probably really necessary. Yeah. I mean, if you're, depending on your setting and what level of survey you're going to do from a cardiac standpoint, it's really, really important. I mean, Dr. McLaughlin can chime in on this, but I will tell you that some of the most challenging things, like I've gone to an OB office to help assess a fetal heart, and doing that with some of the presets that were utilized for obstetrical imaging are absolutely confounding when you want to look at detail in the heart. Some of what we talked about earlier, the cardiac presets, the smoothing, it's vastly different in what we need to have the machine set up to do in order to get the best outcome. And so it can be challenging. And so I would say, go in there. I would challenge all of you guys, go in there and set up a good cardiac preset, because it really does make a world of difference in the things that you can identify and appreciate from a cardiac standpoint.
Yes. Absolutely.
And if you need help, call me. I'm here to help you. I'll be happy to help you. Dr. McLaughlin that's the great thing about having Dr. McLaughlin on. She is such a great resource in the world of fetal echo here in the Valley. We're very fortunate to have her on board with us.
Well, I want to take this opportunity to thank Amy, Jason, and Dr. McLaughlin for taking the time to share your knowledge and expertise on this topic of the anatomical survey. We hope you enjoyed today's session. Please look out for an email that will be coming with the follow-up survey, so to complete that in order to get your CME certificates. And be look on the lookout for other upcoming live webinars and CME opportunities that we will have to share with the community. So thank you all. Thanks again, and we'll see you guys all soon. Stay healthy and safe.
Thank you.
Bye, everyone. Thank you so much.